Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Breast Cancer Screening, Diagnosis, Treatment, and Recovery and is being held in recognition of Breast Cancer Awareness Month. The presenting providers are breast surgeon Marisa O'Neill, who sees patients at our breast surgery location on the campus of Trinity Health Ann Arbor and in Chelsea. Our second presenter will be our plastic and reconstructive surgeon, Farid Nossoni, who sees patients at our Schoolcraft campus location in Livonia and in Brighton and Ypsilanti. So Dr. O'Neill will be our first presenter. Welcome, Dr. O'Neill.
Thank you. Hi, everyone. Thanks for joining us on a Wednesday evening. I'm going to talk about breast cancer screening and a really brief overview of our treatment as well. So let's see. We'll start with screening. So when it comes to breast cancer screening, it can be a little bit controversial because there's a lot of different guidelines and there's a lot of different societies that come up with screening guidelines. Some of them are listed here: the American Cancer Society, United States Preventative Task Force, the National Cancer Community Society, American College of Radiology. And so there's a lot of different data that supports when you should start screening and how often you should start screening. For an average risk woman, the recommendation is to start them annually beginning at the age of 40. We do recommend doing a risk assessment prior to that, and that takes into account things like your family history, your breast density, when you started having your periods, how many children you've had, when you had your first child. And then we recommend doing them every year. New data has come out to really support that. And then the question about when to stop them. And nobody knows really right what our true life expectancy is. But a lot of times, sometimes people say stop them at 75. We say, to catch an early breast cancer in someone who is a healthy 80-year-old, it does a lot more benefit than when they feel a mass and they're, 82, 83 years old, when we could have done something that lessens their need for more aggressive treatment. So mammograms are the standard of care for screening. Screening mammograms have been shown in multiple studies to reduce breast cancer death. And really, the most recent data shows that by doing them annually, starting at the age of 40 for an average risk woman, we are detecting more early breast cancers. So when they compared it to doing them every 2 years versus intermittently, it was basically like a tenfold increase in the percentage of later breast cancers that we were finding. As a breast surgeon, we hear a lot of myths about mammograms, so I kind of wanted to touch on a couple. The first one is that the radiation from mammograms cause cancer. And anyone who's gotten called back for diagnostic mammograms or, brought back again for a repeat in 6 months, you kind of get this feeling of, well, is this going to make my situation worse? Is this going to cause a cancer for me? And the answer is no, because when we look at the amount of radiation that you receive from a mammogram and you compare it to things like your background daily radiation, or for example, if you were to take a transatlantic flight, it's the same amount of radiation you get at that point. So the risk versus benefit of it, we still support doing these annually. And it does not necessarily it doesn't increase your risk of getting cancer. Another one is whether or not you have breast implants. People think, okay, well, it's not safe. Somebody is gonna, pop my implant. And the truth is that it really is safe for implants. Sometimes you need additional time in order to, pull the breast in a certain way or manage the mammogram so we can adequately image the breast. But you can still get mammograms with implants. And then the last one, that you don't need a mammogram because you don't have a family history. And the truth behind that is that about 90% of breast cancer is sporadic. So only, I tell people, about 5 to 10% of breast cancer is hereditary, meaning you inherited a gene that caused the breast cancer. For example, the BRCA gene, the one that Angelina Jolie made popular, um, that increases your risk of developing not just breast cancer, but other types of cancer as well. That's called hereditary. And so 75% of women diagnosed with breast cancer have no family history at all. And which is again the reason why we recommend doing these risk assessments as well as annual screening mammograms. So what are the risk factors for breast cancer? The ones that you don't have control over are being a woman, starting your periods at a younger age, having a later menopause, having a family history, and having dense breast tissue, as well as getting older. Um, so these are things that you really don't have any control over, and they do contribute towards your risk of developing breast cancer. One of the things that is really big kind of right now in the breast care circles is talking about breast density, because the FDA came out and recommended and told us that we needed to put breast density on everybody's uh, mammograms. So we do that. And we also are supposed to send a letter if you have more dense breasts. Why does breast density matter? So if you look at these pictures, breast density refers to the ratio of fatty versus fibrous tissue or glandular tissue in the breast. A is an entirely fatty breast. You see that most of the breast is black with a little bit of white in there. As you move from A to D, you notice increased whiteness in the mammogram. The reason why this is risk is because the denser your breast is, the harder it is to find things within the breast. Dense breast tissue shows up as white, as do cancers. So they can basically dense breast tissue can mask cancers. And so then we can talk about supplemental screening on top of the mammogram. So some supplemental imaging that we talk about are ultrasounds and MRIs. Ultrasounds do not use radiation. They are technician dependent. So sometimes you can get an automated breast ultrasound, which is like what it sounds like. Basically, a machine is doing it. And it does increase the risk of detection in a patient with dense breast tissue. Alternatively, MRIs are, as you see here in the bottom right, an MRI is extremely sensitive. It is going to pick up pretty much anything that is abnormal within the breast. An IV dye gets put through your veins, and we look at something called the kinetics. And essentially, it's going to tell us, hey, is there something that's abnormal than the normal breast tissue? The biggest risk of an MRI, besides you're claustrophobic and you freak out, which normally people who do have claustrophobia do pretty well because you're laying on your stomach and there's two cutout holes and your breast kind of hangs towards the ground. So it's not like the MRI machine, it's like right over your face. But the risk of false positives means that we find something that's abnormal in the breast, and then we do an ultrasound, and then we do a biopsy, and it ends up being nothing, which causes a lot of anxiety for people. But it is also a very good test because it can see through dense breast tissue. I just wanted to note that thermography, although it sounds great to take something where you do not have radiation, like a mammogram, it's not recommended as a screening tool, and it should not be in place of a mammogram. The American College of Radiology has shown that it hasn't demonstrated value in screening, diagnostic, or adjunct imaging. So the recommendation is not to do thermography. And that's a whole kind of separate topic, but the long and short of it is I would not recommend doing a thermogram instead of a mammogram. So then we talk about the risk factors that we do have control over. And the ones that we do have control over, really, they decrease your risk of overall mortality. So sedentary lack or lifestyle or a lack of exercise, um, obesity, even if you say didn't have your ovaries, your body still makes hormones in your adrenal glands and your fat cells. And so obesity increases your estrogen in your body. About 90% of breast cancer is estrogen receptor positive, meaning that it is driven by your hormones. So basically, the more fat, the higher estrogen. And so one of the things that we tell people who have had cancer before is a healthy lifestyle. I mean, it's good for your heart, it's good for your breasts. And then alcohol, the recommendation is for women is one drink per day. Um, I think everything is in moderation. But you know, the last one is taking hormone replacement therapy for over 5 years. Like combination hormone replacement therapy. So this is, something that you're taking. This is estrogen and progesterone together, perimenopausal symptoms. So you're having hot flashes, um, vaginal dryness, that kind of stuff. And so you take a hormone replacement therapy. Well, taking that kind of unopposed estrogen progesterone, risk of breast cancer because of breast tissue. Um, so the uh American can you still see you can still see my screen, hopefully.
Yes, you're perfect.
Okay, thanks. I got like an internet connection issue. Um, so the recommendation in terms of exercise is 150 minutes per week. However you want to slice that up. If you can do it in like 50-minute chunks or however, but of moderate to moderate intensity versus 75 minutes of vigorous aerobic activity. And I think one of the best things that you can do is walk. It's a low impact exercise, and it, you know, pretty much everyone can do it. You can, in Michigan, where the environment kind of decides a little bit for us sometimes when we can walk outside, but you can mall walk, there's so many benefits to walking in itself. But then anything that you can do to exercise, to work your heart a little bit, those all things are beneficial to your breast as well. So, I listed a couple of things here, but anything and everything that you can do is always going to help. And then I put a couple of resources on here. One of the things that Trinity offers is the foundations of lifestyle medicine. And I think there's a big push, like really across the nation, to talk about lifestyle medicine. What can we do? Because we're kind of more of a reactive healthcare system. We'll take care of you once you get sick, but is there something that we can do to prevent you from getting sick? And um, I think that there's a lot of benefit to engaging in that lifestyle medicine conversation. What can I do from a sleep, from eating, from exercise standpoints in order to give me a better overall health? Not just for cancer, but just in general. And then there's a couple other ones on there as well. So that's kind of the screening talk. In terms of treatment, I'm just going to go over a little bit about breast cancer treatment because I think almost everyone is, if you don't know somebody, if you aren't personally a patient, most people, you know someone who's gone through it, and it's scary when you get a diagnosis of breast cancer. And so the more you know, I think the better equipped you are to kind of deal with it. Breast cancer treatment is really a multidisciplinary specialty. We combine surgery, radiation, and medical therapy. And we've been able to really personalize this to each individual. So everyone you talk to, if you know someone with breast cancer, if you were diagnosed, people come out of the woodwork and they say, oh, I was diagnosed. My mom, my sister, my aunt had breast cancer. Every story is a little bit different because there's so many ways that we can tweak what we're doing for people so that we can make it personal, so that we can try and maximize your benefit and minimize the side effects, minimize how much radiation you need, whether or not you need chemotherapy, what kind of surgery you need. So we say that really we're trying to de-escalate therapy. We're not trying to, radiate everyone who needs it or give chemotherapy to people who don't need it. We're trying to really use a lot more targeted therapies, and a lot of information that we've gotten has made from recent studies have made it very nice to really be able to target our therapies. So when we talk about it, we say that it's an intensive treatment, right? It's somewhere between normally 3 to 12 months, depending on the type and the type of surgery that you have, the type of medical therapy that you undergo. So all of that kind of plays into it. From a surgery standpoint, there's really two options. Lumpectomy, which is removing the mass with a clean rim of healthy tissue, and a mastectomy. This is a modified radical mastectomy, which means that we would be removing all the lymph nodes under your armpit, but it's very rare that we do that anymore. We've been able to, again, de-escalate, meaning do less with the same benefit. So from a lumpectomy standpoint, and Dr. Nossoni is going to kind of talk about this as well, we've been able to combine oncology surgery with plastic surgery. So if there's less than, say, 20% of the volume of a breast is what we go by normally, and you have a tumor in there and I want to take that out. Well, I can bring the tissue back together so there's not, this dimple or divot within your breast. The goal from oncoplastic surgery for a lumpectomy is to make the breast look the better or the same as before. Oh, perfect. Dr. Nossoni, I was just talking about oncoplastic surgery. So so if there's less than 20% of the breast tissue, then I can reshape the breast, bring it back together, to really get rid of, so there's not a defect there. If there's greater than 20%, that's when I turn to my plastic surgery colleagues, and we can partner together at that time to kind of figure out how best to maximize the cosmetic outcome. So this is just an example of kind of the oncoplastic surgery that I would do. From a mastectomy standpoint, there's three different options. There's a skin sparing mastectomy, which means that I leave your skin intact. I remove the breast tissue underneath, and then Dr. Nossoni or one of his partners would come in behind and be able to fill that void with something, either your tissue or an implant. A nipple sparing mastectomy is a mastectomy where you get to keep your nipple. And whether or not you keep your nipple is a conversation in terms of the cosmetic outcome. If your nipples are pointing towards the ground, we don't always recommend saving them. But if your nipple is in a good position, then it maintains a better cosmetic outcome. And it actually looks very natural. So basically we make an incision. I take out the breast tissue, and then Dr. Nossoni or one of his partners will come in behind and put either a tissue expander, which we'll talk about a little bit, or an implant in. And then the last thing that we talk about is aesthetic flat closure. And there is a lot of conversation. There's websites about this, and you can kind of look it up, goingflat.com. There's a couple other ones, but basically it's removing the breast tissue and going flat. And I think it's really important that people know kind of all of your options. And we really decide this, again, it's a personalized decision to each person. If I'm kind of in the business to save breasts, so if it's possible, in order to do a lumpectomy. We've actually found that lumpectomy and the addition of radiation to a lumpectomy, the survival is slightly better than a mastectomy, which a lot of times people think bigger surgery, better outcome, but that's not always the case. And it really depends on your specific cancer. A quick note on the lymph nodes. So the lymph nodes underneath the armpit, which are, here's my, right here, that's the first place cancer would go to if it were to travel outside of the breast. So what we can do, we used to take out, all of the lymph nodes, and that increases your risk of getting swelling of your extremity because it can't travel back through the normal path. So a sentinel lymph node biopsy is injecting a couple of tracers within your breast. One is called technetium-99. Basically, these two tracers, one's a blue dye, they go to the first couple lymph nodes that are underneath your armpit that cancer cells would go to. And then I take those out during surgery. And the risk of getting lymphedema is so much less by being able to do that surgery. It's extremely beneficial. And it tells us what we need to know. So again, that's kind of where we're able to do less, but still treat you the best that we need to. The other types of treatment that we couple are radiation and then systemic treatment. So local treatments are treatments that we're going to get rid of the cancer in your breast, and then we're going to try and prevent it from coming back within your breast and the lymph nodes. So surgery does that, and radiation does that. Radiation is therapeutic doses of X-ray beams that kill cancer cells. And there's not systemic side effects to radiation. You don't glow, you can still hold babies. Radiation is a local treatment to the breast. Systemic therapy is what most people fear, right? Chemotherapy. There's 3 different treatment options that we can use from systemic therapy, and it depends on tumor biology. So anti-hormone, if your tumor is driven by your hormones, we can give you something that decreases your hormones. HER2 is a protein on the outside of the cell that we've been able to target. And then chemotherapy, if there's nothing else, or if we find that your recurrence risk, your chance of something coming back is so high, even with using an anti-hormone pill, we would recommend giving you chemotherapy in addition to that. But we run a specific test to be able to tell us that if we don't know already. And it's based on your tumor's genetics. So we run it based on what's sitting in the lab that they've taken out in a biopsy or I've taken out during surgery. And we can tell if your specific tumor has a higher risk of coming back, then maybe it's worth it to add chemotherapy to it. So what can you do? Best things that you can do is get your yearly mammograms if you're over the age of 40. Make sure people in your life are getting their mammograms as well. If you have a family history of breast cancer, it's good to talk about what your risk is to get a risk assessment and potentially a genetic testing. And then, the same things that help with, decreasing heart disease, decreasing your risk of diabetes are exercise and limiting alcohol intake. And that is the end of screening and treatment for
Fantastic.
me.
Hi, everybody. My name is Farid Nossoni. I'm one of the 3 plastic surgeons with Trinity Health IHA Medical Group. I'm very excited to be here to describe and kind of go over some of the things that we do with the breast reconstruction, and also answer any questions that anybody potentially has. With our medical group, all 3 of us, I think breast reconstruction is probably one of the most common procedures we do, and it's something that we are most passionate about. And I think it's something that we are all very interested to help. It's a very large area, and it has many, many different options available for patients. However, it's also very, very individualized. So we all all three of us spend our time to kind of describe all the options to you and go over what's best fit for each individual patient. Because as Dr. O'Neill just mentioned, it's a very, very individualized treatment for each patient, even though there's lots of algorithms and this and that. But when it comes to actual treatment and getting patients back to normal life, it's a very individualized process. So, overview of what I'm going to talk about today. And I'm just going to talk about how breast reconstruction essentially impact long-term recovery and health. We'll talk a little bit about history of breast reconstruction. What does it mean to have breast reconstruction? What surgical options do you have available? And kind of briefly gonna go over options like lumpectomy that Dr. O'Neill talked about, as well as aesthetic closure like Dr. O'Neill also talked about with the flat closure. So in general, the first thing I tell our patients is that we understand that everybody has very, very busy life. And as soon as they get the diagnosis or they get the phone call from pathology or the breast surgeon or the mammogram, something needs to be biopsied, it's kind of everybody's life becomes upside down. Our goal for the most part is to get patients back to normal. And normal life is what we want everybody to be back on. And for vast majority of patients, when you think about holistic care, having a breast mount when they wake up in the morning, when they wear clothing, is part of having it being normal and back to normal. And that's what we are here for. So it's been a long journey since 1889 when first radical mastectomy was done by Dr. Halsted. And that surgery lasted a long time. It kind of lasted for over 50 years. Everybody who had a breast cancer, that's what the surgery that they offered to them. Things obviously have changed since then. And the first implants were introduced in 1960s for reconstruction. Actually, a little bit of a Michigan trivia in that is that one of the first companies that made breast implants, it was Dow Chemical in Michigan. It was one of the first companies that made silicone implants. And believe it or not, I've seen a handful of patients that they still have those implants in place from the 1960s, believe it or not. There's sort of a tissue expansion that is to increase the size of the skin envelope, started in 1982. And that really revolutionized the breast reconstruction because we were able to be more flexible with the size of the implants. And also the advancements in research in breast cancer in general and the great work that Dr. O'Neill and their colleagues have done over the last 30 years with nipple spray mastectomies, skin spray mastectomies, things of that nature has really provided more options for patients. In the 1980s and 90s, we started seeing developmental of microsurgical techniques with using patients' own breast tissue, patients' own tissue from abdomen and thighs and back to reconstruct the breast. And we continue to develop. Again, the goal is to continue to evolve and develop something more aesthetic and functional for reconstruction of our patients. And as I said repeatedly, to get them back to normal life. So the goals of breast reconstruction, I kind of discussed about it. I also want to remind everybody that breast reconstruction in general is a choice. And it's something that we have a discussion with our patients. And if they decide to do it, then we are going to be with them every step of the way. And they can choose to have patients can choose to have a breast reconstruction immediately at the time of mastectomy, which probably long-term has the lowest complication and has the best result. Or they can wait and have it delayed. And that works too. For the most part, that works as well. So there's a lot of options that are available for patients. Another thing to mention is that by law, as part of Women's Care Act of 1998, all reconstruction after a mastectomy is mandated to be covered by all insurances in the United States. So the insurance companies cover everything related to reconstruction, including all the revisions. And if the implants does not work for you, you can switch it to autologous reconstruction or vice versa. All of those are going to be available for life for patients. So that's another thing to kind of like at least have some ease when it comes to reconstruction and recovery from breast cancer. So the three principles when it comes to functional breast reconstruction: breast footprint, breast conus, skin envelope. And to have an adequate breast reconstruction, it's important to have an adequate interactions between all of these to provide the best type of reconstruction. So the breast footprint is the outline the breast makes over the chest wall. The footprints forms a foundation of the overlying tree structure of the breast. The chest wall is stable, but it's unique to each individual. That's very important, especially if we see with breast reconstruction patients after mastectomy. You want to make sure you stay within that footprint, because the implants tend to like to travel laterally. So we have to work very hard to try to make sure it stays in the medial footprint of the chest, as opposed to kind of migrating underneath and more laterally. The breast conus is the 3D shape of the breast, projection, volume of the tissue that is over the anterior portion of the chest. When it comes to implant-based reconstruction, I will discuss that a little bit further down in a few minutes. We have a lot of options when it comes to different kinds of implants, and they have different projections, different volume, and different texture, different profile. That is individual. We try to fit it to each individual themselves to have the most functional and aesthetic appearance after the breast reconstruction. And the skin envelope is essentially what's the well-fitting bra that holds the conus and the breast into the right position. And that's redundancy can lead to odd shape and form. Lack of skin quantity can lead to flattened look. And that's something we are very careful. And that's one of the reasons we studied the expansion, and we work very closely with our breast surgeon colleagues to provide the best results for patients. So the final shape and the appearance of the breast is the interaction between these three things that I talked about: the skin envelope, the chest wall, and the breast conus. Now let's talk about the methods of reconstruction that we have available. And that's kind of going to be the bulk of my discussion today. So there are really three types of breast reconstruction that is offered in the United States right now. The most common type is implant-based reconstruction. Around 70 to 80% of reconstructions in the United States are done with implants. Autologous breast reconstruction, which means using your own tissue, probably comprise around 20%, 15 to 20% of breast reconstructions. And implant plus autologous tissue reconstruction is something that is probably around 5% of breast reconstructions in the US right now. And it's usually not something we offer initially to patients except for specific types. So let's talk about, let me just see what I have here. Okay, perfect. So let's talk about implant-based breast reconstruction first. So with implant-based breast reconstruction, we usually can have it done in two ways. One is in a two-step fashion, which vast majority of patients fall into that category. And some patients it can be done in one stage with going directly to implant. So with the two-stage procedure, and that's the most common type, I would say probably around 65 to 75% of all breast reconstructions are done that way, is that at the time of the mastectomy or later on, after Dr. O'Neill or one of her colleagues have completed the mastectomy, a plastic surgeon, myself, or one of my colleagues, or in general, any plastic surgeon who you have talked to and you have made a plan with, would come in and place a tissue expander. The tissue expander, essentially the goal of tissue expander is to promote the growth of the skin. There's a kind of relatively, it's not hard, but it's relatively plasticky looking material. They can go under the muscle, pectoralis muscle, or over the muscle. And there has been a big shift in breast reconstruction over the last few years. 15 years ago, all of these implants and tissue expanders went under the muscle completely. And now most of the vast majority of them are over the muscle. They each have advantages and disadvantages that we'll talk about in a little bit. But in general, nowadays, most of these implants are over the muscle. So the tissue expander is placed, usually at that time, patients have a drain, and We usually do not fill the expanders, maybe a little bit with air, just to kind of start that process, but we normally do not expand them at that time. Once the drains are out, usually around 2 to 3 weeks after surgery, the healing is complete. Then we start the expansion process in office. These tissue expanders, they all have a little magnet in them. We use the magnet finder essentially, and we'll inject sterile saline, and we slowly, between 50 to 150 cc a week, we start the expansion process. As I said, the goal of the expansion process is to promote the growth of the skin. It's not just to stretch it, because we want more vascularized and viable skin. Because the better the skin envelope, like we talked about, that drapes over the conus, which is going to be the implant, the better the long-term result. Once you are now at the size that you're happy with, and when it comes to the tissue expander, there are multiple factors that we consider. One is the size, but most important is the base diameter. You remember we talked about the chest wall diameter and how it's important for the implant for the breast to sit appropriately on the chest wall. So we don't want something that is too wide, and we don't want something that's too narrow. So that chest wall diameter is the most important factor that we look at when it comes to placing a tissue expander. So once now we are at the size that we are happy, we usually wait. There are lots of, if there's a new adjuvant treatment that is needed, that will be done at that time. If not, we still wait, usually around 1 to 2 months after that. The reason we wait is anytime you place a foreign body, that could be like from knee replacement to breast implant or anything that you put into your body will form a capsule around it. It's essentially a scar tissue, an envelope that covers that tissue expander or implant. And we want this capsule to mature so we can kind of control it a little bit when we go to the next stage of the procedure. And that's one of the reasons we wait. We also need the skin to completely heal and have excellent blood supply to it before we go to the next step. So once we have done that portion of the procedure and we have waited and expanded appropriately, then we go back to the operating room. The second surgery is going to be a lot straightforward and from a pain standpoint, significantly easier for patients, and it's almost always outpatient. At that time, we take the tissue expander out and we place an implant in that pocket. And if you have to do any pocket work to adjust the pocket when it comes to positioning, we do it at that time. So if there are 20, 30 different kind of tissue expanders, there are probably hundreds of different kind of implants. And that's where that individual treatment would come into the picture to some extent. The goal is to get you in the implant that is a perfect size, perfect projection, perfect base diameter, and perfect profile for each individual patient. So there are tons of different implants available. They have different base diameter, different amount of fluid of silicone that's in them, and different texturing that they have. The implants can be saline filled or silicone filled in general. For breast reconstruction in general, most patients opt to have silicone implants because they appear significantly more natural. And they're also slightly lighter, actually, believe it or not, than the saline implants of the same size and shape. The advantage that saline implants have over the silicone implants is that if there is a rupture, then they can be monitored. You know immediately that they're ruptured because the breast deflate and it can be addressed. Silicone implants can have silent ruptures. But the good thing is that nowadays they are so cohesive, these silicone implants, that there is no risk of leakage or things like that you hear. So it doesn't affect the overall health of the patient. And even if there is a rupture, God forbid, it stays within the compound of that implant. It doesn't go anywhere else. If there is any supplemental thing that needs to be done, it's done at that time too. Like things like fat grafting. That is when we liposuction the fat from the abdomen or thighs or back. We process it, and then we inject it into the skin envelope to get rid of any rippling that you could see from the implants and provide a better shape for the patients. Those will be done all at the same time. And again, the implants are in general very safe. and very, very well tolerated on patients. There have been some issues with some things that you see in the news. Any risk factor with implants are in general very, very low, and there's something that we'll discuss in detail during our visits. But patients tend to do very well with these implants. It's not, we call them permanent, but they're really not, because we still have to monitor them. The FDA recommends us getting an ultrasound or the MRI at 5 years and then every other year. And for the most part, they last nowadays with the new implants 15 to 20 years before they need to be exchanged. So they last pretty long time and they're relatively speaking very safe. And vast majority of patients tolerate them very well. So that in a nutshell was an implant-based reconstruction. There are select few patients that if they have an excellent skin envelope and a discussion that we probably the breast oncological surgeon and plastic surgeons have together, then it can be done as a direct implant. But even those patients, they end up usually having some revision surgery down the road. So they did a study of over 20,000 reconstruction. And in general, most patients have between 2.2 to 2.3 surgeries when it comes to their reconstruction, no matter what kind of reconstruction they had, 1-step implant, 2-step implant, or autologous. And speaking of autologous reconstruction, we can briefly talk about autologous breast reconstruction. That is when we use the tissue from the patients themselves and use that to reconstruct the breast conus. Tram flap was probably the most common thing that people did in the 80s and 90s. And with the advancement in microsurgical techniques, we started offering more and more microsurgical surgeries. So the DIEP flap, also known as deep flap, is probably the most common type of breast reconstruction autologously that is done nowadays. That is, then we remove the tissue from the lower abdomen and we transfer it with the blood supply attached to the chest wall, and we connect it under the microscope to the blood vessel to the chest wall, and that continues to receive blood supply from patient. Very effective surgery, very fantastic results, and is an excellent choice to some patients. Patients who have history of radiation, patients who are very young and they don't want to have implants for the next like 40, 50 years. Overall has excellent results, but obviously it's not for everybody because it's a significantly more extensive surgery. That second surgery after the tissue expanded could become significantly more extensive. But that's also an option is available for patients who do not want or cannot have implants done in place. The third type of reconstruction is a combination of both. That is when we usually bring a muscle from the back and we kind of like cover it with an implant. A latissimus dorsi flap, probably the most commonly used flap for that. But that's, again, something that we usually do not offer initially. It's usually a backup plan for patients who failed the first two types for whatever reason, or if they're not a candidate for the first two types of reconstruction for whatever reason. As I said, it's a very individualized treatment. Usually, the first time that patients come to us, we spend over an hour talking to them about different kind of options, and we have a pamphlet, and I always tell them, like, I know I'm going to talk too much and give you a headache, but we'll come back and we'll talk more. But I'm trying to just give them all the information, so at least they have an educated research that they can do, and they will come back and we'll talk more, and we finally make a decision together. But we try to make sure patients have information to make the best decision for themselves and for their family. So that in general covers breast reconstruction. I know it's just a very, very quick review, but that's kind of in general is a breast reconstruction as it's done nowadays. There's advancements and research that is being done, but in general, that's what we do. When it comes to nipple areola reconstruction, something that patients ask us a lot for patients who are not a candidate for nipple-sparing mastectomy. And Dr. O'Neill mentioned that as I was just getting into the Zoom after 15 minutes of struggling with my internet and then my phone. Not everybody is a candidate for nipple-sparing mastectomy. We usually they have two criteria, and Dr. O'Neill, correct me if I'm wrong. My understanding was when I was a general surgery resident, the mass had to be at least 2.5 centimeter away from the nipple for patients to be a candidate for it from an oncological standpoint. And from a plastic surgery aesthetic standpoint, you want to make sure that the position of the nipple is at the level of inflammatory form. So if natural ptosis has occurred, it really is not the best option. Even sometimes patients are like happy with their naturally ptotic breast, but reconstructed breasts tend to be a little more perky, for lack of a better term. It tends to sit a little higher on the breast tissue, on the chest wall than natural breast. Therefore, it will not look appropriate to keep it. So nipple areal reconstruction is available. There are many local flaps and skin grafts that are available. But honestly, nowadays with the three-dimensional tattooing, which is done relatively very cheaply, and we have multiple tattoo artists in the area that do a very, very good job of it. That's something that is really, I usually tell patients to just go get a tattoo because it just simply looks better than any surgery that I can provide to them. So that's also another option that's available for our patients. I'm not going to talk too much about the lumpectomy. I think Dr. O'Neill kind of talked about it. But if you're having a lumpectomy, oncoplastic breast reduction is a very, very reasonable choice. This is a kind of an illustration of what can be done. It's really a surgery that can be offered to patients like Dr. O'Neill mentioned, when more than 20% of the breast tissue needs to be removed, doing a lift or a reduction is an option. Also, patients who just have large breasts and they just kind of want a reduction to begin with, and they have problems with the neck pain, shoulder pain, things like that. If they're interested in that at that time, something that we can address, because after radiation, then we have to wait a very long time before we can do another surgery on the breast. So that's something that we can kind of like try to use that option in coordination with the breast oncological team to provide that option to patients as well. And for the most part, that is also covered by insurance companies. But that's an entirely different discussion. But the oncoplastic breast reduction is a great choice for a lot of patients as well. And what if you don't want to have a breast reconstruction? That's a very reasonable choice for a lot of people. There are many, many options available for patients. When it comes to aesthetic flat closure, is essentially a post-mastectomy chest wall reconstruction. It doesn't have to be done at the time of the mastectomy. It's actually usually better to do it later, so we allow all the swelling to kind of settle down and do it in the next step to make sure all the incisions and all the lateral tissues are removed. If liposuction needs to be done, some of the edges need to be smoothed out. Those all can be done in a timely fashion, but usually in a delayed fashion. Usually tend to have a better result. But the goal is to provide, remove any lumps or bumps, trim any excess tissue, and restore the appropriate chest wall contour with clean symmetrical incision. And it can be done again at any time, immediately at the time of the mastectomy, but more preferably usually a few months after in a delayed fashion. And these are some of the kind of like the incisions when it comes to aesthetic closure. For patients who have a larger breast and they want to have a little bit of a breast mount, but not a very large breast, using a Goldilocks procedure, the anchor incision right here. Ooh, I kind of messed it up. That's probably the best option that's available. But again, many options available for patients, and we are, all of us here from the breast oncological team to the plastic team are more than happy to talk to everybody and kind of provide those options and discuss different things with patients and with everybody. I pretty much covered what I was going to talk about. If there's any other questions.
Okay. I was just gonna say, from an oncology standpoint regarding nipple sparing mastectomies, MRIs give us a great idea. And a lot of times we do a preoperative MRI. It gives us an idea how close that it is to the nipple. And honestly, you know, we have them, the pathologist will look. And if something's abutting the nipple, it's pretty easy to go back and just take a nipple off. But all the studies have shown that leaving a nipple, as long as it's not within the nipple itself, is pretty safe. it's as safe as doing a standard mastectomy and removing the nipple. So like Dr. Nossoni said, we look at that and make sure that it's really not abutting the nipple. If the cancer looks at all like it oncologically, we will do it like a skin sparing instead. There is some great questions out here. So the first one is, what is the new treatment for males with breast cancer? And I apologize for not addressing male breast cancer. It does, we see about 1% of breast cancer as male breast cancer. We treat males very similar. We kind of extrapolate the data that we have because there's such a low amount. It's very hard to make studies purely based on men. And so we extrapolate what we do for women. Typically, male gets a mastectomy because it normally is starting right behind the nipple. That's the most common spot. And men don't have a lot of breast tissue. So ultimately it becomes a mastectomy because we're removing it. And then we, again, do the sentinel lymph node. As long as they don't have lymph nodes that are positive on presentation, they can get radiation. There's reasons that we give radiation after mastectomy, but for the most part, adding radiation is normally with a lumpectomy. And then again, the majority of male breast cancers are hormone receptor positive. So we will give them an anti-hormone pill similar to what we give to a lady. It's for a male, we give them tamoxifen, versus ladies have a couple different options. So good question about the male breast cancer. We typically don't send those over to you guys, Dr. Nossoni.
No.
Most people most males don't get reconstruction, at least in my experience.
No, that's true. Yeah.
The next one is, what are the recommendations for follow-up treatment or both after a mastectomy for stage 1 HER2 negative lymph nodes? So the follow-up, we don't recommend imaging after a mastectomy. If you have reconstruction, then Dr. Nossoni was talking about, doing an ultrasound or an MRI to assess the implant. But typically how we follow people after a mastectomy from an oncology standpoint is you follow up with us, a breast surgeon, in our office annually. So once a year for 5 years, and we just do a clinical breast exam. We feel the skin envelope. That's most likely where we would find a recurrence. And the second one was about reconstruction. Dr. Nossoni, you want to take this one?
Yeah, the question was, is reconstruction possible or recommended 5 years after mastectomy, non-nipple spraying? Absolutely. You always have that option available. Again, it depends on the patient, the other comorbidities, the BMI, radiation versus no radiation. But overall, it's very much possible. Actually, we recently did one that was like 6 years out, and patient did fantastic. So definitely is an option. Yeah.
Absolutely. What is your opinion of using anti-hormone therapy when risk is higher than the general population because of family history, but no pathogenic variant has been found in genetic analysis? So can other people see these questions? I'm reading them off because I think people.
Yeah, no, just you. So it's great that you're reading them.
Oh, okay, perfect. All right. So, my opinion is that I think quality of life plays a big deal into what we do. There has been studies that show that short-term use of hormone replacement therapy, normally about a year, is okay. We would recommend using estrogen, just estrogen, because the combination of estrogen plus progesterone actually increases your risk more than just using a single, like estrogen. And depending on what the symptoms are, is it for hot flashes? Something that I've found, and I don't know if it's anecdotal, but a lot of people say vitamin E oil helps, like a capsule, helps with the perimenopausal symptoms. And again, vaginal estrogen is, I feel like that's worth it. If you're telling me that you're having hot flashes, like, hey, people tell me they're going to get a divorce if they don't take hormone replacement therapy, or they're going to, they're gonna murder their husband. I'm like, please, you got to do something, right? So I think a lot of it is a discussion of what what is the use it for? What are you using it for? And how can we kind of give you that quality of life using some other things? But if it comes down to that, there is a safer method to do that. The next one, does having implants impact mammography?
I can take
And
that one.
yeah, okay.
Go ahead. In general, I think Dr. O'Neill already mentioned it. Patients have had reconstruction with implants, then they obviously don't need mammography anymore. The imaging study of choice would be MRI or an ultrasound at 5 years, and then every other year after that. Secondly, for patients who had augmentation for cosmetic reasons, no, it does not affect it, but I think they need an additional view that is required for those patients.
Yes, agreed with that. I had a left breast cancer with partial mastectomy. I have lost a cup size. Is it possible to have right breast reduced to equal? Thought and anything I may think about beforehand, please. This is great. I mean, I think both of us love answering this question because the answer is yes. And Dr. Nossoni, take it away.
Yeah, absolutely. The answer is yes. Decide that you had a partial mastectomy in 2006, and if the radiation was not at that side may not be the easiest side to lift or reduce, but definitely we can reduce the other side to try to at least significantly improve the symmetry, and that's definitely an option for you. Absolutely.
Yep. And I, when he was talking earlier, symmetry procedures are covered by insurance. And so anything that you do related to breast cancer, including to the opposite side, is something that should be covered by insurance, which is fantastic. And one of the things that he just kind of mentioned was that radiation, it's hard to do surgery on radiated tissue. It just takes the elasticity out of the tissue and it makes it harder for it to heal. So we're all for making those equal. And I think that there's, in terms of is there anything you could think of beforehand? I would say, talking to the plastic surgeon, and just having your appropriate screening done before surgery is our biggest recommendations.
Absolutely.
What do you do surgical and treatment wise for when cancer is close to the chest wall? So this is a bit of a rabbit hole that I could go down, but from a treatment standpoint, sometimes, normally the order of treatment is that we do surgery first. However, if there's reasons that we would recommend chemotherapy first, this would be one of them. And we do this, it's called neoadjuvant, meaning before surgery, chemotherapy. And what that can do is it can shrink the tumor, making it pull away from the chest wall, meaning that now it is not attached to the chest wall. If it's not attached and it's just close to the chest wall, well, that's okay. But if let's say we did surgery and it was still, close to the chest wall, and when we did the surgery, they found what's called a positive margin, then we would just use radiation and other treatments in order to make sure that it doesn't increase your risk of recurrence. Hopefully that answered that. Okay. Where do fatty tissue start to form in the breast, or are you born with it? You got it from your mama. Fatty tissue is that's just how you were born, basically. Normally, all of our breasts as we're younger are pretty dense and then and very glandular. And that's because we have babies and our breasts are producing milk and other things. So but as we get older, our fibroglandular tissue begins to involute and it becomes more fatty. Patients who don't have that involution, meaning that it doesn't turn more fatty, that's why they're at an increased risk because they have higher density later on. Okay, can my primary care refer me directly to you for reduction of my non-cancer breasts? Well, they can, yes, to Dr.
So,
Nossoni.
yeah,
So,
absolutely.
yes. They would just put in a referral to plastic surgery and and the purpose would be for a reduction.
Yeah, and usually if the primary doctor put it in, and you're within the IHN network, someone from our office will call to schedule either with me or by two partners.